Welcome to Adapting Person. Thank you for deciding to watch this video. This is a quick video giving concept you need to pass your NCLEX regarding fractures. We'll talk about key aspects, how to manage it, and the content you need to know. Very straightforward. This is a straightforward concept mastering regarding fractures, and you would like to stick around to learn this for your NCLEX. There's no question regarding fractures that will beat you in terms of management. First question on the screen just to set the record. We'll come back and deal with this question later. The patient is brought to the emergency department after falling off a ladder. X-ray confirmed a displaced spiral fracture of the right tibia. The nurse understands that the spiral fracture is typically associated with which of the following causes? Is it a direct blunt trauma? Is it a twisting force? Is it bone weakness due to osteoporosis or compression injury? Number two, a patient presents with an open fracture of the tibia. The nurse anticipates that the initial treatment plan will include which of the following? Casting the limb to prevent further injury, immediate surgical debridement or stabilization, administration of anticoagulation to prevent clot formation, apply a tourniquet to control bleeding. So our lecture to start with fracture. Like I said, the first thing we'll talk about is management of fracture and things you need to know about fractures. So let's get to it. What is a fracture? Everybody know what is a fracture, but the simple way to define it is what? It's a broken bone. You have a broken bone. That is the definition of a fracture. What is the risk factor? You don't have to know anything. It's just a broken bone. What are the risk factors that will cause you to have fracture? One, straightforward, right? If you don't move around, bed rest. So immobility. Immobility is number one. It can lead to osteoporosis, muscle atrophy. Steroid use, medication, this also can cause a problem. Patient on corticosteroid look for fracture due to osteoporosis. And of course, osteoporosis, weakness in the bone due to mineralization problem. And trauma, if you have somebody you fall, like the question says, or you bang your head or anything like that, or somebody hits your leg or anything, you can have a fracture or based on the force, right? There's some medications too. You should be careful too that the NCLEX sometimes may give it to you, like PPI or omeprazole, right? These can lead to decreased calcium calcium absorption issue and then osteoporosis. So watch for those kind of traffic questions. So these are five things I think you should know in terms of risk factors associated with fracture. If you know about fracture, you should know about signs and symptoms because that's what your board may ask you. So how do you know this patient is having a fracture? So what is the signs and symptoms you should pay attention to? Signs and symptoms. Number one, they're going to have pain because the bone is broken. There will be swelling because the bone is broken. The bone will don't look straight, deformity, right? Because the bone is broken. There may be crepitus. If you touch the bone, it will look like it's moving along. You have the squishing sound. It's not aligned. The muscle around the bone will go into spasm. Okay. And then the patient will not be able to bear weight. So inability to bear weight of the affected um, extremities. So that one too is going to have a problem. So that's the key aspect of it. Okay, we'll talk about management, but just something to came to my mind, so I just need to let it out right now. Um, in terms of management, when we talk about a full management, this is something simple you have to know. The management depends on type of fracture. In all of them, number one, you want to stabilize the fracture, stabilization, because that will affect healing. So if it doesn't stabilize, you have no union of the bone. Okay. Some people will say he has no align appropriately when it completely healed. So that is the key aspect of it. But if you see the word non-union of bone, yeah, that's what it means. So that's the other thing too you should worry about is to prevent infection. That's number two. Like I said, it depends on the kind of fracture that you're dealing with. Okay. So next one we'll talk about this related to type of fracture, right? You have to know types types of fracture. What does that mean? The first thing you should know of is a closed fracture. Is it a fracture closed? That means the bone is not exposed or skin is intact. How about that? Skin is intact. Or it can be open. That means skin is broken and the bone is exposed. Remember, if the bone is exposed, biggest problem is infection. So that's what you have to worry about. So this is how you can distinguish fractures. Is it closed or is it an open fracture? Then is everything broken? Complete fracture. So you have it through and through. So the bone is broken all the way, all through and through fracture. Oh, it can be incomplete, right? As you can see, it's partially broken. This stick and your ankles will use this way, grain stick fracture. It's basically partially broken fracture. Is it close? Is it open? Is it complete or incomplete? Then the angle that is broken, you have to know. So it can be oblique. Oblique basically telling you that the fracture is angled, right? Or it can be compression. Somebody is compressing on the bone and that causes injury. So compression fracture, right? This is an impact. Something smash it and they compress it to a certain. It's different from crash. Crash fracture. When you crush the fracture, you trap, like you trap under the car, or there's a tornado and then everything fell on you, right? Those worry about what? Rhabdomyolysis or compartment syndrome. When your body give you a crash injury to somebody who had a crash fracture, just pay attention to rhabdomyolysis where the creatinine will go up, they have myoglobinuria, and they have renal failure, and then hyperkalemia. You have to worry about. That's the key aspect of it. Okay. There's some fractures that I know caused by crash or compression injury, but we call them spiral fracture, right? Spiral fracture. What is the problem? You see a break at one end, then the other end is burned. So those are the two features. There's a break. You see where the fracture is located, but one end of the fracture is burned away. That is what we call spiral fracture. How does it occur? It's mostly non-ambulatory. So people don't move like kids, young babies, right? 1 year old who cannot move, who is not walking, 6 months old, who is not walking, and they have this fracture. When you see that, think about abuse and you need to report it to the providers. How does it happen? This happens from twisting. So twisting injury is the normal one cause of spiral fracture. So when you see it, it makes you worry that the kid is being abused. So you need to report it. The fracture can occur. It will not be spiral, that means break and spiral fracture. It can break or burn, but it may have displaced from one end. So displaced fracture. Displaced fracture, that means one end is misaligned. That's misalignment. This is the main reason why we try to stabilize fracture so that it can heal and prevent non-union. If you have a displaced fracture, you can also have a non-displaced fracture. That means you have the fracture there, but the two bones are close to each other. They are lying. It looks straight, but it's broken. That is a non-displaced fracture. If it's not displaced or displaced, then there are those that the bone is completely gone, comminuted. That means you have like shattered grasses. Yeah, you have it. Shattered fracture basically um, is comminuted fracture. Basically, everything is shattered and then like a glass. So that's one thing you have to know when they give you that kind of fracture. There is also stress fracture. How does that happen? This is due to wear and tear, or you use the bone too much, repetitive use, and you can have this fracture occurring. The last one is pathological fracture. These two underlying problem, like if you have prostate cancer, you have cancer metastasis to your bone, yeah, then you can have fracture due to pathological. And these you can put osteoporosis there too. These can lead to pathological fracture. For your bone, you need to know certain specific fractures. So I'll put them different colors. These specific because they're special fractures. They are special fractures, and I want you to know something about them if you see it in the question, right? The first one is hip fracture. Hip fracture. How do you recognize a patient has a hip fracture? Like, how do you know patient has hip fracture, right? The first thing you should look for, you look for the leg. The leg will be abducted away from each other. It will be externally rotated. The same thing, rotated outward. And then the leg will be foreshortened, right? It's a little bit shorter than one, the hand is shorter than the other end. That is foreshortening leg consistent with the hip fracture. The muscle always get into trouble. So the muscle will have spasm. So muscle spasm, okay? And then if you look at their groin, you're going to have pain. You're going to have pain in the groin. And when they bearing weight on that end. So these are features. Look for selector apply. This is what they will put in selector apply. And if you check, they will have ecchymosis around the hip. So watch for those key features in order to be able to distinguish between hip fracture and other pelvic fracture. The second one is mandibular fracture. Mandibular fracture is different. Is your jaw, basically. Think about it. Most of the time when it's fractured, they have to wire it. So they have to fix it, wire the jaw intact. When you do that, the individual will be drooling, and that's airway issue. So that's your priority. Make sure you suction them as much as possible. And there may be some bleeding also. So this is something you should know about mandibular fracture. The common one that sometimes they can ask you in a neuro case or a case form is a basal skull fracture. And you know what you're supposed to look for, right? Raccoon eyes, you have the battle signs, and then you have rhinorrhea, right? Runny nose with the CSF leak from your nose. Those are features you have to know. What is the next function you're supposed to know? No NG tube. Tell the patient not to blow their nose, okay? And not to blow their nose. Keep their head upright, at least 30 degrees. And then what to look for is halo sign. That tell you the leaking CSF and the risk of infection. That no NG tube, absolutely no NG tube in this patient. Okay. The next one is Colles fracture. You may have heard about it before. Um, how does this happen? This is what you fall down or fell down with outstretched and you try to break your fall. So breaking your fall, when you're falling down, you stretch your hand to break your fall, and at your wrist to break the bone there. So this is really, really involved the distal radial fracture. In the individual who have pain at the wrist, your priority, number one, is neurovascular check. Make sure they have sensation, the blood flowing, and they can feel you. That's number one. So when you see this kind of fracture, pay attention. Colle fracture, distal radial fracture, fall from an outstretched hand when you try to break your paw, and check for neurovascular check. Pelvic fracture is a big deal. Okay, when you have pelvic fracture, number one things that a board will ask you is hemorrhage. So look for signs and symptoms related to hemorrhage or tachycardia because they're bleeding or there may be blood in your urine. These are the signs, or ecchymosis around the perineum or urethra medius. You will see ecchymosis around there tell you the individual have had pelvic fracture. And most of the things that will happen is mostly hemorrhage. So hemorrhage is your priority. Spinal fracture, you know it. The most important one for your body is above T6. So if they are fractured above T6, it's a problem. What are the things you should worry about? Neurogenic shock. And the individual will have what? Hypotension and bradycardia instead of tachycardia because they have lost the sympathetic nervous system function. So that is the difference between hypovolemic shock and neurogenic shock. The treatment is to give them IV fluid followed by pressors, right? Norepinephrine, epinephrine. So you fill the tank, then squeeze it. That's the key. If you see a question on neurogenic shock, fill the tank and squeeze it. So give them a bunch of fluid, then you give them norepinephrine, but mostly norepinephrine to squeeze it. The second one is autonomic, is reflex, yeah. It's basically signs and symptoms of ICP due to what? You have constricting clothing, overstimulation, or impaction with stool, or urinary retention. And that's what causes the problem. Number one thing you need to do first is head up, like an ICP. Then check their rectum, check their bladder, check you remove constrictive clothing, and observe them before you treat their blood pressure. But number one is upright, then search for the offending agent. That is the key to manage this patient. Okay. Now, nursing management. This one is few key facts you need to know for your board nursing management. Number one is you got to do the assessment. You'll be able to tell what a fracture is, right? I told you deformity, signs and symptoms of fracture. There's deformity in the leg is foreshortening. They have ecchymosis, they have crepitus, and all those things you have to know, right? Those are the things you have to know. Then do neurovascular check, looking for the 6Ps, right? Preclurothermic, polar, pain, paresthesia, pulselessness, and then paralysis. These are the remember paresthesia is number one for compartment syndrome. So these are the things you look for early on. And then you want to like what? Make sure X-ray is ordered related to that. The third thing, fourth thing you need to know is immobilization. Therefore, this is like putting a cast or splinting. This is to align the bone to allow it to heal much proper. So proper healing. healing. That's the purpose of stabilization, right? Stabilize your bone, prevent bleeding, and allow it to heal. Sometimes they put traction, you know, and ensure if they have traction, there's later I'll do a video on traction. They checking the pins and the alignment is perfect, and the weight is appropriate being used. Okay, so those are the things. And you got to manage their pain management. They can be pharmacological. What does that mean? Elevating the leg and putting ice on it. Don't and then rest it. These are the things we tell them pharmacological management of pain management for this patient with fracture. The major things you should looking for is compartment syndrome, as I said from the above, the 6P, or fat embolism. How do you know somebody have a fat embolism? They have a long bone fracture. And what do you look for? Well, look at the skin. They'll get petechia. Look at their brain. They will be confused. And look at their lung. You have dyspnea. These are the three things you should be looking for. So somebody have a long bone fracture, all of the sudden is confused. He has petechia and then he has dyspnea, he has fat embolism. What do? Just stabilize the fracture and supportive care. There's nothing you need to do. Support the patient, but it's a priority patient you have to worry about. Infections, especially if the bone is, you have an open fracture, worry about osteomyelitis, right? That's a problem. Okay. And the last one, DVT, deep vein thrombosis, because of the immobilization, and you have to give them anticoagulation. So this is a brief, quick way of analyzing, giving content related to fracture, necessary management, type of fracture, how to take care of it. And therefore, let's go back to the question. A patient is brought into the emergency department after what? Falling, right? We talk about it, falling off a ladder. X-ray confirm a displaced spiral fracture of the right tibia. The nurse understand that a spiral fracture is typically associated with what? Following cause. I told you it's a twisty motion, one end is broken and burned. The number one thing you need to know, you can look at it as a test taking strategy. You know it's not a compression problem, right? You know it's not pathological fracture because there is no osteoporosis. Patient there's no osteoporosis. They will tell you about bone mineralization, and there's no direct pressure, right? It's mostly twisting motion. So B is your right answer. The patient presents with the open fracture of the tibia. The nurse anticipate that the initial treatment plan will include which of the following? Where casting the limb to prevent further injury, immediate debridement and stabilization, administration of anticoagulation to prevent clot formation, apply alternately to control bleeding. Keyword in the question, open fracture. Number one problem with open fracture is infection. So B is your answer. Thank you for watching. Like I said, if you want more, subscribe. The link is over there. Share the video if you want to join the channel, or you can join our membership where you get all the videos on adapting. It's very cheap. Anything you want to pass your NCLEX. And then if you want a live course, our crash course is coming up. Take care and have a good day. Bye.